So, welcome to another episode of Heart Core Junction. Today, I want to speak about medication, and I have leading senior pharmacist Fiona Miller with me today, who's had over 37 years' experience in the public and the private healthcare setting, as well as in community. She also has had 20 years as a lecturer at a university, and her passion and what she specializes in is cardiac medications and heart failure medications. She also loves to educate people, especially on cardiac disease risk factors such as quit smoking. So please welcome Fiona Miller. So welcome, Fiona. Thank you for so much for coming to the podcast today.
Thanks, Alex. Thanks for having me.
And it's a super special day too, because I know it's your birthday today.
Yes.
And so I'm doubly honoured that you want to spend time with me on a podcast on your birthday. So thank you so much.
My pleasure.
But can we begin? I want to know a little bit about yourself and what led you to become a pharmacist.
Well, it's always a decision of what do I want to do with my life. And for me, I had a family friend who was a pharmacist, and I just really respected the way that they worked in their community and that they contributed and that they cared about the people, who walked into their shop. And I thought, gee, that's that's what I'd like to be when I'm that age, and that's who I'd like to be. And I've never regretted that decision.
And you specialised in cardiac and heart failure medications.
Mm-hmm.
Is that something you always wanted to do or just landed that way?
Oh, look, I've worked in quite a few areas, Alex. I even had a little go at working in a children's hospital, but that didn't settle. That didn't sit well for me. So I've always worked more with chronic type of conditions, diabetes and cardiac medicines. I used to work on the cardiac wards in the hospital and medical wards, respiratory diseases, so conditions that people have to live with, and also older people. I've worked in nursing homes and as well. So looking at that, living with rather than trying to be cured from. If
living with
sense.
all those chronic
living
diseases.
with chronic conditions and living your best life, regardless of your age.
So can you explain the role of a pharmacist in terms of cardiac and heart failure medications?
So primarily, I think our place is to explain, to help people understand the benefit of their medicines, as well as potential risks or things to watch out for, but to really put some context around why a person would be prescribed a particular set of medicines, and why and how long to stay on them, what's the issues if you don't take them. So just that bigger context for people. I think quite often when you're unwell, you get given a lot of information in hospital and everybody's doing their best to tell you everything you needed to know. And then you leave hospital and I hear from people it's a little bit like all of a sudden being on your own and you're supposed to remember everything that you were told. So I really like being able to unpack that a bit and come back and say, well, what do you remember? And let's move on from there.
It's true. It's so daunting, isn't it? You're a patient in the hospital and you've got so many people coming to you, and then you've got to take this, you've got to take that medication, and you don't really remember and retain it all until really when you get home. But then when you get home, I'm alone now. I don't really understand all these medications.
Yeah, or all the terminology that gets thrown around the room. Yeah.
So what's the difference between a heart attack and people having a heart attack that leads to heart failure?
Well, I'll try and keep it as simple as I can, Alex, without, I guess, I'm not trying to talk down to people, but
no, we want to keep it nice and easy.
Nice and straightforward. I think always having a mental picture is the best idea. So you would have explained before that the heart muscle is a pump. So if you think about any pump, a pool pump, for example. So a pool pump has like a case. It has plumbing. It has electrical leads going into it. It has a place where, water goes in and water comes out again, and that's just like your heart. It's a pump. So if we think about the things that can go wrong with the heart, if you think about the plumbing aspect of it, if we don't have enough blood supply to the heart muscle, of course it will be damaged. It might be temporarily short of oxygen and damaged, or it might be permanently scarred. If we think about the electrical system of a pump, that's how how your body instructs the heart muscle to beat. If we have a problem with the electrical system and we're not getting that signal through, then of course the muscle is going to beat irregularly or in a way that's potentially going to cause some quite significant problems. And if the muscle itself is damaged, like, for example, a pool pump with, the casing of the pump is damaged, got a big dent in it, let's say, I don't know. But if the heart muscle itself is damaged, then it can't beat as strongly as it should. And that means it can't push the blood out of the heart around, into your circulation. So it's not one condition, but there's an interconnectedness between the damage that's occurring to the heart and the consequence of that.
Right. Great explanation. And that means there is a difference in those medications that are administered and prescribed, aren't they? So, for example, when somebody has a heart attack, I call it the golden five that they're always discharged with. They have their aspirin, they have an antiplatelet like clopidogrel or ticagrelor. Then they have a blood pressure one like an ACE inhibitor, let's say ramipril. They have a beta blocker, let's say metoprolol. And then they have a statin for cholesterol and possibly a GTN spray as well. So if we
the bag.
Yeah, the bag of
Bag
golden
full.
ones. And then they go, oh my goodness, I got all these medications. What do they all mean? So can we just sort of go through what the golden five do actually mean and why are they so important for them to take?
Well, Alex, I have to tell you as well, there is in Australia just very recently some new guidelines about the medicines that a person would be prescribed after a heart attack.
Okay.
And so I think we'll see some changes in what is the classic everybody gets, because that's what we've always done. Everybody gets these, and then everybody stays on them lifelong. And then some years ago it was, actually, you don't need that one lifelong necessarily. Remember to talk to your doctor after a year. Now, the new guidelines are suggesting that we be even more targeted to the potential risk of ongoing damage. So even that will be changing. And I've heard GPs already asking the question of, why has my patient not been discharged on, for example, ramipril? With a little bit of head scratching, haven't we always done that automatically? And so and that's what's interesting about the research in cardiac disease is it's always emerging. It feels like we're always adding medicines. But this year it's really nice because we're saying maybe not everybody needs everything forever. So, yeah.
Right, that's good, isn't it?
Yeah. I think that's really, really helpful. But it also reminds me to remind your listeners, it's a good opportunity to spend some time with your GP, maybe once a year, once every couple of years, to say, can we just revisit all of this? Has anything changed? Is there any reason I could stop taking something? Is there any reason I actually need to revisit the dose and increase the dose of something based on how I am now, not how I was 2 years ago and 10 years ago?
That's right, with coronary artery,
Correct.
Disease.
Yes.
And it's like the
It's
old
not a
blood
one
pressure
thing.
medication, isn't it? They were always on blood pressure medication.
Yeah.
But that's because they had coronary artery disease. And like you say, that hose pipe was getting more and more blocked. So the pressure's got to go up. That was their high blood pressure.
Yeah.
And sometimes you do find after a heart attack and they've been stented and you've got this beautiful blood flow that blood pressure can normalise as well. So it is that discussion that they have with their GP, isn't it?
Yeah. And so coming back to what you're saying about medications. So yes, after a heart attack, a person will need to be on 2 antiplatelet, anti-clot medicines for a period of time. That's to protect the heart against further blockages, further clots forming inside the arteries that feed the heart muscle, particularly if you've had a stent holding that blood vessel open. So that's really important. How long a person stays on those 2 anti-clot, antiplatelet medicines depends on several factors, and that's something that really needs to be discussed with the cardiologist. And but if they've given you a time frame, whether it's 1 month, 3 months, or 12 months, please don't stop early. I encourage people, please don't stop early. The risk of a second heart attack is very high if a person doesn't follow the guideline that's directed towards their condition. So it's quite a high risk within days of missing those medicines.
Yeah. And I've actually phoned clients, maybe within 7 days of discharging, and I say, are you still on your medications? Oh, no, I threw them in the rubbish bin. And it's like, why did you throw them in the rubbish bin? Oh, because I was bruising, but they're on this anti-clot, so then they do bruise.
Yeah.
But they didn't realise, and I said, well, can you grab it out of the rubbish bin? No, the rubbish truck has come this morning.
No. Oh, no.
And then it's like, you've got to make that phone call. Can you please phone your GP? You need to be on this medication because this is preventing anything sticking to that brand new stent.
Yes.
But once they got that education, then they realised the importance of that medication.
Yeah.
And it's all education, isn't it?
That's right. So that's the 2 important antiplatelet medicines, anti-clot. The next thing we think about after a heart attack is that the blood supply to the muscle has been restricted to some degree. That might mean that the muscle's just a bit cramped. I'm sitting with my legs crossed. If my underneath leg might get a bit of a cramp in it, might go to sleep. Okay, my toes would tingle and my foot's asleep.
Right.
If I uncross my legs, okay, it all comes back again. Takes a little while. If I left my leg trapped underneath a tree, injured, eventually the muscle will be permanently damaged. Yeah. So for your heart muscle, if there's very minor damage from the heart attack that looks reversible, looks like the muscle's just gone to sleep. We call it stunning, but it's just gone to sleep because it didn't have enough blood supply. But the expectation is that it will all come back to normal. And there doesn't seem to be any actual damage to the muscle itself. And the doctors can tell that with ECGs and echocardiograms. And so we won't get into the diagnostic side of it, but the expectation is that muscle will recover. But if the muscle itself is already damaged, then there is risk of heart failure. And heart failure is where the muscle itself isn't able to eject the blood the way that it should. There's lots of types of heart failure, but heart failure after a heart attack is very much about the muscle itself being damaged. And in that situation, it's extremely important that we try and protect that heart muscle from getting further and further and further floppy and damaged and weakened. And that's what the medicines like ACE inhibitors like ramipril, perindopril, things that end in pril or things that end in sartan like irbesartan or candesartan, those medicines help to maintain the health of the muscle itself so that people don't develop heart failure. If a person has evidence of heart failure already on top of their heart attack, those medicines are critical for keeping that heart muscle as strong as it can be and allowing it to heal. And there are other medicines that we use for heart failure as well, but particularly, so this is where we're now looking at it and saying, does everybody need a pril, an ACE inhibitor type medicine? Or is it only the people where there is a prediction that they're at risk of developing heart failure? If somebody doesn't look like they're going to develop heart failure, maybe they don't need that. So this is the kind of emerging. Do we treat everybody the same, or do we look more carefully?
Right.
So that puts the option of 3 medicines. And then, of course, there's the beta blocker. And beta blockers are there to take the strain off the heart while it tries to heal. Okay, they relax the blood vessels. They get blood flowing more easily around to feed the heart muscle itself, the big blood vessels that sit around the heart muscle. And so your beta blockers, they take this, they relax blood vessels. They also take the drive. Your brain drives your heart muscle, your heart to beat hard and fast, and the beta blockers take that innate pressure drive off the heart muscle, the heart itself, so that it can relax and fill, it can heal. It's not beating too fast, it's not trying to beat too hard. And so once again, we look at beta blockers being helpful for angina, chest pain. They're good for blood pressure, although we don't usually use them for blood pressure, but they do help with blood pressure. But the important thing that they do after a heart attack is to give your heart a rest, to give it a chance to take the strain off and just heal for a period of time. And so, and they have some effects on the electrical function. They slow your heart down as well. So they may help with reducing some of the electrical twitchiness of your heart after it's been damaged. But the point then from that is that in a year, if all has healed and you're doing well, then we can revisit, does this person really need to stay on a beta blocker? Maybe yes, but some people, well, many people, no. For many people, it's all about healing and then revisiting.
Yeah, because that's the question a lot of them ask is, do I need to stay on these medications forever?
Yeah.
And especially the beta blockers and the ACE inhibitors to give you a cruising heart rate and give you a cruising blood pressure.
Yeah.
Their biggest question to me has always been, do I need to stay on these forever?
Okay.
So it's good with that emerging new information coming out that, no, they don't need to be on that forever. Maybe
yes, maybe no. It depends on the individual. And this is and the important thing about that is that comes back to the tests, that everything that happened during the heart attack, after the heart attack, and in that year since the heart attack, all the healing that's occurred or not. And sometimes it's nobody's fault. The heart muscle just doesn't heal particularly well. Many people, yes, some people, no. Even if you've looked after yourself really well. If you haven't looked after yourself really well, of course you've decreased the chance of your heart healing. So it is very much around being able to revisit what happened at the time, what has happened since, and therefore the decision needs to be guided by your cardiologist and your GP, not that sort of, I think I'm okay, so I can stop taking this. And of course, we should talk about the statin medicines, the classic cholesterol-lowering medicines. But statins, I was thinking about this, and I hope this explanation makes sense, because I've never said this one to you. You've heard me talk before, Alex, but I've never said this to you before. I was thinking about statins and people saying, oh, do I need to stay on this because they lower cholesterol? My cholesterol's fine. Yes, that's great. They're doing their job. Do I need to stay on this statin? Why do I have to take the highest dose of statin? I'm fine now. So we know that statins also protect the lining of the inside lining of your arteries, your coronary arteries. We know that they make any plaque that's in your coronary arteries more stable, more fixed, so it's less likely to rupture and trigger a heart attack. So aside from the whole cholesterol numbers part of the story, we know that statins have a protective effect against future heart attacks and strokes and kidney damage and some other conditions, because they reduce the risk of the plaque that is already there rupturing. And of course, if you've had a little stent, there's a bit of artery this side and that side, sometime, and in your carotids and elsewhere in the circulation in your legs. So all of those arteries need protecting, and statins do that. And the thing I was going to say is when people say, well, do I need to stay on this? And do I need to stay on the highest dose? I thought about it like I know there's a lot on the news about home invasions, and the rascally, let's say rascally kids, let's say, sneaking in and stealing people's cars. And we all see it on the news with the security cameras. Okay, so if you were the person who, out of the blue, your car was stolen at night, and you the next day you thought, well, I don't want that to happen again. I'm going to put in some security cameras. And you put in some security cameras. And after a year, you haven't been robbed again. So you think, oh, well, I'll just take all those security cameras away. I don't need them. Do I need these security? I've never been robbed. Or would you leave them there?
Great analogy,
Like,
Fiona.
would you leave them there, or would you say, I don't need this anymore? The guy down the road just got robbed. What about if you had a couple of home invasions? You'd had one car stolen one night, and 6 months later your car is stolen again. We hear about that, don't we?
We
in
do.
some areas, some suburbs, unfortunately. And you had security cameras. Would you want security cameras maybe on your front gate as well? Maybe you'd want a gate, as well. You'd think about, what is my level of risk in this suburb? In my body, what is my level of risk? And this is where we look at cholesterol lowering. We look at the other medicines, and we ask for this person, what is their level of risk? How hard do we push to protect against that potential future heart attack or heart failure or another condition that emerges from having this coronary artery disease?
Right.
And so, the dosage of statin isn't so much related to your cholesterol numbers. It's about how much risk does this person have of a heart attack in the first place, even if you've never had one, or after a heart attack, how much risk is there of another heart attack? And let's target that. Let's keep those security cameras turned on,
keep
people.
them on.
Keep the security cameras turned on. Please take your statin medicine.
So a big question is, if I take the cholesterol medication, will it reverse my existing plaque that's already in my coronary arteries?
No. Okay. It will. There is some evidence that it will regress a little bit. So the degree of blockage might ease back a bit. We know that. There is no magic medicine that removes plaque altogether. It just doesn't happen. It does regress a little bit because we're correcting the balance of toxic versus healthy cholesterol. But it doesn't go altogether. But it does become less risky. Yeah.
Okay. And what about people say, but I get muscle aches on a statin?
Sure. Yeah. So now, of course, I'm a pharmacist, so, medicines to me are my bread and butter. But for somebody walking around who's never taken medicines, came out of hospital with a bag full of 5 or 6 things, and also maybe got told, oh, and by the way, did you know you've got diabetes? And it's like, oh, gosh. So for me, it's easy to just say, well, all medicines have side effects, but they do. You can't put anything in your body without somebody reacting to that. So all medicines have side effects. And for statin medicines, one of the most common side effects is a little bit of muscle achiness. It's probably about 1 in 10 or 1 in 20 people gets that, which means 9 don't. More than 9 people out of the 10 don't. Well, one might. It can be quite minor, little bit of achy discomfort, and usually if we drop the dosage down, that resolves. Or if we swap it to a different statin, that resolves. So our approach is always, let's try. If you have a problem with your medication, please talk to your pharmacist or talk to your doctor. Our job then is to work out what your body handles best. Personally, I really don't like to hear people told, oh, well, it's doing you so much good, you have to put up with that. I wouldn't want to hear that myself. So I'd much rather say, right, well, tell me more about that. let's work out how much of a problem it actually is, and let's see if we can find an alternative or a way to manage the perhaps side effect that a person is experiencing to make things tolerable, or switch it to something else that doesn't cause that problem for that individual.
So you've got alternatives, which is
there's
great.
Always
an alternative.
there's always the opportunity to at least sit and explore alternatives. Yeah.
Okay.
Before we just throw everything in the bin.
And the last medication there I want to tackle is the GTN spray.
Sure.
The little red bottle that you spray under your tongue. What does it do, Fiona?
What it does? Well, it relaxes the blood vessels that are feeding oxygen to your heart muscle. So by relaxing that blood vessel, you think about it like a hose pipe, big car parked on the hose, no circulation, take the car off the hose pipe, blood flow again. Okay. The GTN relaxes blood vessels. It gets blood flowing again, or flowing more, and so that cramping in the heart muscle is relieved because oxygen is coming back to the heart muscle.
Because that vasodilation, isn't it?
Yeah, that's right. Dilating the artery, or the blood vessel. Now, of course, because when they do that, they can dilate blood vessels elsewhere in your body. So most people who have a dose of under-the-tongue GTN spray get a bit of a headache, a throbbing, pounding headache, because their blood vessels are relaxing elsewhere and they get a pounding sensation of blood flowing. It might make them very lightheaded or dizzy because your blood pressure can drop. It's not why we're using it, but that can happen. So we advise people, if they need to use their spray, please sit down. Stop what you're doing, sit down before you use your spray. Okay. The GTN spray, handy hint, listeners. GTN spray doesn't work if it's at home and you're out.
So true.
Have it with you, all right? You might not ever need it, but have it handy, have it with you. You might be the person who's sitting out socially and somebody else needs it and they didn't bring theirs, and you might be the person. I mean, you don't want to give it to somebody who's never been prescribed it, but your mate might have said, I didn't bring my spray. Yeah, I've got mine. Yeah.
And just replace it once a year and never leave it in a hot car.
That's
Goes
right.
off a lot quicker.
That's right.
Because sometimes I'll say to them, oh, no, it's in my car. It's in the glove box.
Yeah, no.
And it's about a 40-degree day.
Nothing likes to be in a hot car, right?
No. So let's now talk heart failure medications, Fiona. And those were our golden five we normally spoke about. But there's heart failure medications that are additional to or in replacement of. So, for example, like the dapagliflozin, what does that actually do? That's a heart failure medication, but what does it do?
Well, just briefly, Alex, there's lots of reasons why people might get heart failure as a completely separate condition. So just bearing in mind, heart attack doesn't always lead to heart failure, and heart failure doesn't always come from a heart attack. There's lots and lots of reasons. The big one, I should say, and maybe one of your doctors will speak about this one time, but we are seeing a lot of younger people at the moment with heart failure caused by recreational drugs, by testosterone use, and by alcohol use. So, substances that are toxic, they're poisonous to the cells of the heart muscle itself. That's just as an aside, to remind us to always come back to the cause. Why is the heart being damaged? If we don't fix the cause, it doesn't matter how many medicines you take. You've always got to address or explore the cause of why the heart muscle is being damaged. So if we think about heart failure, we have to think about, well, what was the original cause? And we've talked about if it's a heart attack, those medicines would be there. There are some other medicines that we use for heart failure specifically that are there to either strengthen, to assist the heart muscle to strengthen, or to try and remove the reasons why the heart muscle is becoming more damaged. Okay, and it's a little bit complicated how your body responds to heart failure. And there are new medicines for heart failure. We worked with the same medicines for 30-something years. And then in the last couple of years, I'll say 5 or so years, we have 2 fantastic new group classes of medicines that have been shown to reduce the likelihood of a person with heart failure ending up in hospital again. So they reduce the severity of the heart failure that would put you into hospital. And they improve the likelihood of your heart muscle healing. It doesn't mean everybody needs those medicines, but we're very proactive now in managing heart failure so that the heart muscle heals quicker. And of course, that means less long-term risks. Yeah. So there's a class of medicines, we call them, I'll give you the technical term, we call them SGLT2 inhibitors. So you might see it written down as SGLT2I. And in Australia, we've got 2 of those, dapagliflozin and empagliflozin. You can pronounce them however you like, but the lots of people say them in all different ways. That's one of the ways. And now these are really clever group of medicines, and they were originally designed as a diabetes medicine. And for diabetes, they work to increase the amount of glucose that is excreted in your urine. So they instruct your kidneys to push more glucose out rather than staying in your bloodstream. So that's one of the useful ways that diabetes can be managed. But in people with heart failure, you don't have a problem of high blood glucose. So we found that, or it was found that people with diabetes who went on to one of these medicines, dapagliflozin or empagliflozin, had improvement in heart failure if they had heart failure. Their heart failure improved. They did better. They didn't end up in hospital as frequently with exacerbations of their heart failure. And in fact, we now are seeing that they reduce the risk of future heart attacks or severity of cardiovascular disease. So it's really interesting, this careful observation of what a new medicine for diabetes did, watching what happened to those people and seeing, there's something more to this medication. There's something more it's doing in the body rather than just pushing out glucose. Now, what is that something else? It's pretty complex in how it actually works on different hormones in the body, and to be honest, there's still debate about that, and the deeper you look, the deeper explanation you get. However, we know, on the simplest sense, they correct a bit of fluid imbalance. They lower blood pressure a little bit. They manage the salt imbalance in your system. We know they also have these effects on reducing, we believe that they will reduce or improve fatty liver disease. We believe that they can also improve the high uric acid that's part of gout. So it's really more around what are they doing to balance or bring our metabolism closer to normal. There's in this whole metabolic syndrome, what we would call metabolic syndrome, and so they're really I don't want to say magic pill. I want to say
I was going to say wonder drug. It's got so many modes of action, doesn't it?
So many actions, but so many interconnected actions. And I'm not trying to promote the medicine. I'm just saying it's been a really interesting time in the last 5-10 years to watch this evolution of a medicine that's not just working on one thing, but it's actually working on the several areas of your body to improve that whole big metabolic dysregulation and that connectedness. Because we know that people with heart disease have a higher chance of gout, and people with gout have a higher chance of sleep apnea, and vice versa. And all of those conditions have a higher chance of erectile dysfunction. And so a body is not one thing.
No.
A body's not a heart and a separate kidney and a separate liver, and
and yet this drug is multifactorial,
it's
isn't
multifactorial.
it? It works on
Yes.
so many different
Yes.
aspects of the body.
That's right. And so some people will be, they're protective for kidneys if you have kidney disease. So some people would be prescribed that medicine just as a diabetes medicine. But if you have heart disease, it would be prescribed for benefits for your heart disease. If you have kidney disease, for benefits for your kidney disease. And in the future, probably maybe also for people just with non-alcoholic liver, fatty liver. So a range of things we'll see them emerging for.
So have these SGLT2s, are they now a standard line of medication for a heart failure patient?
Yes. Oh, yeah. They're a gold standard for most types of heart failure. If your heart muscle isn't very damaged, or if it's recovered very well without you having had a chance to start that medicine, then maybe your doctor might say, look, we'll just work with 3 medicines, not 4. But most of the time now, if you have heart pumping function damage, so what we would call reduced ejection fraction, where your heart muscle isn't able to pump out of its ventricle into the body at a normal volume of blood, then it would be textbook gold standard now to start one of the SGLT2 inhibitors as quickly as possible. And so for heart failure now, people with reduced pumping function of their heart muscle, for the most common sort, the expectation now, or what we aim for, is for people to be taking the 4, we call them the pillars, the 4 pillars of, or the gold standard, or the guideline-directed medical therapy for heart failure. And that would be one of your prill medicines, or a newer medicine called Entresto. It would be a beta blocker. It would be an SGLT2 inhibitor. And it would be another medicine that we call either spironolactone or eplerenone, that work once again to balance the hormones that are, or chemicals or hormones that are potentially damaging the heart muscle itself. So all of those are protective. None of them are going to directly magically heal the heart muscle, but pretty much maintain, reduce the likelihood of things getting worse. I always think of it more as being about dampening down your body's inappropriate response so that the body itself can have a chance to heal rather than fight itself. So these medicines are all about allowing your body to do what your body would normally do to manage pumping function of your heart.
And so then that begs the question again, that if you've got permanent heart failure, you would be on these medications for life, wouldn't you?
Yes.
Because without them, you're going to end up with fluid overload and real diminished heart function, isn't it?
That's right. If you have an uncorrectable cause of heart failure, and you bring this up with, it'd be really interesting to hear one of your doctors explain this in their terminology. But if you have a damaged heart muscle that is from a permanent cause, such as scarring after a heart attack, without the medicines, it is highly likely that scarring will extend, or that the muscle, the floppy misshaping of your heart muscle will not get better on its own. And often without the medicines, it will get worse. We never really can say it will get worse, but in our observation in heart failure services around the world, if people stop their heart failure medicines, either inadvertently or because they've chosen to without medical advice, they may still feel fine. You know, if you were feeling fine and you thought, I'm all cured, I'm all well, I've run out of this medicine. I won't get the script filled. And eventually you just stop taking things. And you might feel fine for a year, 2 years. And over time, though, that heart muscle is going downhill again. Its strength is going downhill again. The strength of its ability to pump blood is going downhill again. And we meet those people again. A year or 2 years later, they're back in hospital with fluid overload, feeling terribly, terribly unwell. It's a horrible sensation to have heart failure, to have an exacerbation of heart failure. And the second time round, it's much harder to heal that heart. So it tends not to heal as well the second time. So we really encourage people to stay on those medicines lifelong. We come back to the security system. You know, what we're doing there is protecting against future damage.
Against future damage.
Yeah. And allowing the heart to do what the heart wants to do.
Pump blood.
Pump blood.
Yeah. So you talk about spironolactone and frusemide in terms of heart failure as well, and fluid overload. Can you just explain to the audience what their mechanism of action is?
Oh, crikey. Okay. Well, I can a little bit. Yeah, just a little bit. All right. So when we think about fluid tablets, and sometimes we call them water pills or fluid tablets, the proper name is diuretic. What those medicines do is they instruct your kidney to excrete more fluid. So your kidneys are filters. They're up the top in the back here, Alex. They're not down near your butt. They're right up here, your kidneys. And you can't even feel them doing it, but they filter waste out of your blood. And they also balance the amount of fluid in your body. So when your heart isn't beating strongly enough to deliver adequate blood per beat, your body thinks, it must be because I don't have enough blood. So it starts to retain fluid. It's just a normal mechanism. If I didn't drink enough today, my body would start to retain fluid. I wouldn't pee as much. Now, when you have heart failure, one of the responses is that you will retain fluid because your body has misunderstood the message and is trying to give you enough circulation. That fluid overload's really uncomfortable and it only makes things worse. It just strains the heart more. So
and
we're getting
happens
into
quite
this
acutely too.
Oh, very. It can happen really fast. It can happen slowly, and people don't notice it, and it can happen really quickly. So diuretics instruct your kidney to excrete more fluid, to filter more water out and excrete that. And that makes people more comfortable. The most effective diuretic we've got for significant fluid overload, we call it having fluid on board. That's just you've got fluid on board, that if you're retaining fluid or you've got puffy, then furosemide is the most effective one for that, most effective diuretic. And the lowest dose we use is 20 milligram, and about the highest I've seen in a long time is 400 milligram. So we can use the amount of diuretic that your body needs. Some people just need a teeny little bit. Some people only need it once or twice a week or only very occasionally. Some people need 4 tablets a day. It depends on that person and that person's heart function. And we adjust that dose. And furosemide, the job of furosemide is only about keeping you comfortable, having the right fluid balance, not putting that the discomfort of fluid buildup, fluid retention. Spironolactone is another medicine that often gets called a diuretic or a fluid tablet or for fluid overload. But it's interesting because in heart failure, we don't tend to use it at the diuretic dose. So for it to be a really good fluid tablet and to instruct your body to excrete fluid, you need to take 50, 100 milligram, maybe even a couple of hundred for some people. but we don't use it that way in heart failure. We give people 12.5 or 25 milligram, a low dose, because we're not really using it as a full fluid tablet. Its effect is more to dampen down one of the chemicals that is actually produced by a kidney and is toxic to muscle cells. So your body has overreacted. It is overproducing particular hormones. So aldosterone is the one that at high levels is damaging your heart. It's your own body that's doing that. So by dampening that down, we're once again reducing the amount of damage to the heart muscle.
Right.
So this is why we use that routinely. Even if people don't retain fluid, we're using it for its other purpose.
Because of its effect on aldosterone.
Because of its effect on aldosterone. Now, it is still a fluid tablet, a diuretic. It has a supportive effect to furosemide. So together, because they work at different areas of the kidney, it's a little bit like saying, well, let's flush the fluid this way and let's help it a little bit this way. But that's it has the two purposes, and that means we like people to be on spironolactone long term, regardless of their fluid balance.
So what are some of the misconceptions you see in regards to people taking their medications?
Well, I think we've sort of talked a little bit about, do I need to take them forever?
Yeah.
That's always the first question is, how long do I need to take this for? Do I need to take it forever? Is it going to cause significant harm to my body? Is it going to harm my kidneys? Is it going to harm my liver? And they're all good questions to ask, and they're important questions to ask. Side effects, it's always important questions to ask, and there's always a side effect list this long in the packet and 2 sentences about how useful the medicine actually is.
And don't Google.
Yeah,
Speak to
a professional, put it in context. We need to understand most of the things on that list we've already thought about. So it's important to have that conversation with either your doctor and or your pharmacist if you have concerns about your medicine. Or questions. That's what we're there for, right? It is always a person's choice, Alex, to take medicines or not, okay? I will say that. We all have our own free will and right to do what we choose to do.
Yeah, absolutely.
But you can't make that choice if you don't have the right information, So having a good understanding, having the opportunity to say, what would happen if I didn't take this? Is there an alternative? But also listening to the information that you're given and making sense of that. If it didn't make sense, ask again, okay? I think that's the only way, or that's what we would call informed decision making. And I think that's the most important thing, is to take the time to make sure you're comfortable with the information you're being given. But if you want to do, if you want to think about coming off medications that have been prescribed for your heart, please talk to your pharmacist and your doctor first. Some medicines shouldn't be stopped abruptly. Some, it's really important not to stop for a period of time, and we might negotiate that, as we said before. Would you stay on this for 12 months and then we revisit the idea?
Or titrate down.
Can we bring the dose down a little bit to get some benefit rather than none? If you're having a side effect from a medicine, is there something we can do instead rather than you just not feeling comfortable to take it? Even with your statin medicines, there's if people do have significant side effects, then some is always better than none. One of the international experts in cholesterol and lipids, that professor says 1 tablet twice a week is better than none because of that stabilising the plaque. So there's always a way, if you have a conversation, for us to try and work through an answer with you. I think natural medicines comes up a lot as well. So the role of natural medicines, and I'm always in my practice, I'm always happy to sit down and listen to people ask, why. The question with natural medicines is, my question is, why are you taking it and what are you asking it to do for you? If you're putting it into your body with anything, what are you asking it to do? If it's doing something, it's a medicine. It may be a natural medicine, but it's a medicine. If you're putting it into your body and it's doing something, then it might also be clashing with something else.
Yeah, because we're seeing more the likes of cannabis oil too.
Correct,
And
yeah.
people taking it to help with insomnia, to help with pain. It's got a multitude of things that it can help with. But people do ask, can I take my cardiac medications, but I'm on cannabis oil?
Yeah.
As
Look,
well.
it's the right question to ask. I can't give you a yes or no answer now because there's so many heart medicines and also for other conditions besides the ones we've talked about today. But the important thing there, as you said, just be open about these things. Ask the question, I am taking or I want to take this. What do you think about? Okay. And if I do take that, what is the consequence? Okay. So if you're on 2 antiplatelet, anti-clot medicines, will the supplement that you want to take increase your risk of bruising? Will it actually stabilise plaque? Will a natural medicine lower triglycerides but not do anything for LDL? The internet might say cholesterol, but what does that actually mean for you as an individual? So I like to think about natural medicines as medicines as well.
Yeah. So, Fiona, how does the body handle when people are on multiple medications, let's say greater than 5 or 6 medications?
Sure. Yeah. It's pretty common now. We call it polypharmacy. Polypharmacy textbook means, more than 4 medicines, but you only have to have one medical condition, one chronic medical condition now, and it's not surprising to be on 4 medicines that are all doing something beneficial in different ways, as we've talked about with the heart medicines. And of course, if a person also has diabetes, maybe also has depression or epilepsy or an unrelated medical condition, things that you take a medicine for one condition, you might take multiple medicines for another condition. You might also have emphysema or rheumatoid arthritis. A person isn't necessarily just one thing. So 2 ways to look at that. Medicines, well, this will sound silly, but people ask me, when I have all of these 6 tablets on the table, do I have to leave half an hour between each one? How will they know where to go? And well, that's not an unreasonable question.
No, it's not an uncommon question.
Do I have to take this tablet and let it find its way, and then do I take the next one? Will they get in the way of each other getting to the right place? No, that's fine. They will, unless we tell you otherwise, your medicines will find their way. The ones that need to go to your brain, the ones that need to go to your kidney to be effective on your kidneys or your blood vessels, find their way through your bloodstream once they've been absorbed from your stomach. If a medicine can't be taken at the same time as another medicine, because they will block each other's effect or not let each other absorb, your pharmacist will tell you. So the timing of your medicines needs to work for you. Often we say take this at night or this in the morning. Ask the question. It's a nuisance. If you're a night shift worker and we've said take all of these things in the morning, you might be driving home at daybreak and be going to bed and you might forget those medicines. So what we tell you to do needs to fit in with your life, not what I've instructed you to do. So that's important question to ask as well, saying this is a nuisance taking these. Tell me, how can they fit into my life better? Regarding medicines for people with multiple health conditions, and that's part of the role. Certainly your doctor will be looking at the combinations of those medicines, making sure that they all support each other, or at least don't clash, don't have contraindications or or inhibit the other one's effect. So we don't want a person on a medicine that increases your blood pressure if we're trying to lower blood pressure. There's antidepressants that can put your blood pressure up. We don't want that. So we would choose an antidepressant that doesn't put your blood pressure up. And that's the role of a pharmacist as well, is to keep an eye on those things. So you might not see them doing it, but back there behind the counter, their brain is always ticking over, watching that big pile of medicines that you handed in. And if, for example, a person started a new antidepressant and you're also on these other medicines, then my brain would be just automatically going clickety, clickety, click. And also my computer would remind me if it was a serious concern, but the GP's computer would remind them as well, hey, this medicine and this medicine don't go well together, or there's a potential for some, you might need to do a blood test or something to check on that. The pharmacist's computer will remind them as well. But for the more subtle ones, we also use our brain. Or we might also ask you to say, watch out for this and let me know. If you are more dizzy, let me know. If it causes, anything that's unusual for you, let me know. So we try to be quite proactive about that, but I can't predict everything, and I always like a person to tell me, how are you feeling?
So you collaborate a lot, don't you? You're really the person between the patient, the client, and the GP. So you would liaise quite a lot with GPs?
Sure. Yeah. If I was ever concerned about, if I was particularly concerned about the medicines that a person was prescribed, GPs have no problem having a conversation about that. That's important. It's why we work together. Because it's all about what is going to be the best outcome for you, the person. Similarly, I talk to cardiologists if I have questions or concerns. Sometimes it's about I'm seeing this and it's not doing what we expected it to do, and you're not going to see them again for a year. Do you want an earlier appointment, or shall I send them to their GP, or what should this person do? I think that open line of communication is really important. Everybody is there. It's all of our jobs to support the health of that individual person, okay, patient, person. You're walking around as a person in the world with this net of your nurse, your doctor, your specialist, your pharmacist, who are just trying to keep that net safe around you. But if you don't tell us, then we can't talk to each other either. Okay, so you need to maintain that dialogue with your health professionals. Sometimes people say it's tricky to talk to my doctor. They don't have long appointment slots anymore. It's tricky to talk to my pharmacist. They're so busy. You have to say, I need to talk. Okay, be proactive. I need to talk. And I've got 3 questions to ask. Write that down before you go in there. Health professionals will always make time for you. And if they don't, well, maybe you need to choose a different one.
Right.
Yeah.
And you talk a lot about health and that you're there to help support other people in their health. So I do have a personal question for you now. What do you do for your health?
Well, I'm very fortunate genetically, Alex, that I don't have cardiovascular disease in my family, on my side of my family. So I'm very lucky that way. But when we think about health, we think about the whole body, right? It's your social health, your mental health, your physical health, where you sit in your society. And I think, so the 2 things that are particularly important for me are relaxing exercise. So I'm not a runner or a lifty in the gym person. I like yoga, I like dancing, I like things that relax my muscles, relax my mind. So for me, that's the exercises I prefer, are things that also engage my mind and relax me from a busy day and take my mind away from work, and being able to put work and other issues into a little box while I focus on myself.
Yes,
Yeah.
I have seen you at the odd concert because you and I both like dancing.
Oh, yes. Well, okay, I should say fairly vigorous dancing when we get started, Alex.
Fiona, thank you so much for coming today. I really, really appreciate it, especially being your birthday.
Oh, that's okay.
And I just so appreciate the work you do in this special space because it's so vital that people have got a pharmacist in their pocket, you know, a pharmacist that will collaborate with their GP. So it's such a vital space that you're working in, and thank you so much for coming
That's all
today.
right. And Alex, I will say, look, people are always told there's no such thing as a silly question, but people are often embarrassed to ask, or they think they've understood what they've been told. But please, if just ask the question, any question.
Any question. Thank you so much. Thanks for watching another episode of Heart Core Junction. If there's any episodes you would like me to discuss, just email me at info@heartcoregroup.com. Also, like, share and subscribe to keep watching my podcast. Alternatively as well, you can contact me and have a look at my website at heartcoregroup.com. Thanks.